This presentation was recorded at the 12th International Conference on Rapid Response Systems and Medical Emergency Teams.
In 2010, I went to a conference in Adelaide hosted by the Safety Commission on the rollout of the National Consensus Statement, and I sat in that room listening to some educators from Adelaide, from Flinders, talking about how they'd been to a conference the previous year and they'd got off the plane at the end of it and said, "We have to do something, let's do this." I did exactly the same thing. I went back to my hospital as a nurse educator and said, "Oh my God, we need to do something." At the time we had a code blue system, which basically was a Met call system, but everything was just called as a code blue, whether you were blue and dead or whether you were deteriorating. And I got together with some staff, some equally interested staff, some nurse educators, some managers, and we talked about it. And then we went to the quality improvement nurse. At the time we had a very little safety and quality unit consisting of one person for a 300-bed hospital, so that's how high safety and quality was ranked in our organisation. And said, "We need to do something about this, what can we do?" Well, 6 months later, the CEO at the time had listened and had said, if we change the proposed statement of duties to at the time we were the Northern Area Health Service, we will make that then a permanent position, 12-month permanent position. We were actually just looking for a 6-month project position. So that's how it all started. Now, since then, that was in 2011. So in 2011, we were the Northern Area Health Service and the hospital was the Launceston General Hospital. A few years later, we were the Tasmanian Health Organisation North and we were still the Launceston General Hospital. And I think, cross fingers, we are now the Tasmanian Health Service, a statewide service, and I still am at the LGH. So why I say that is that throughout this time where we were trying to establish our system in the north, Tasmania, for those of you who don't know, there's this big line across the middle and there's a key to get through to the south because we don't like to agree on anything. So when I hear places like, there's these statewide services and I just think, oh my God, the day will come one day. We don't do that in Tasmania. We tend to go, well, we're doing it this way in the north and then south will do it their way and then northwest goes, we'll just do this. And so there's no consistency, and we now have a new CEO appointed, Dr. David Alcorn, who's come to us from Melbourne, as the CEO of our statewide health service. So we are in a constant state of change and uncertainty, sorry I keep whacking that, in terms of what to do. So throughout this 4-year journey, all of that's been happening in the background. And for anyone who's been through that, it is quite difficult. But our motto was always, if the key unlocks the office door and the pay's in the bank, then I'm pretty confident I've still got a job. So on that note, I'll just say throughout this I've chucked in some pictures from Dr. Matt Brain. He said don't plug his name, but Dr. Matt Brain is our one of our ICU intensivists, and he's our clinical lead for Standard 9, and he's been off doing some study, and I'm not sure if Liz is in the room, one of his colleagues, who's got a poster out on display with some work that they're doing. These are some shots of his taken around the state in between. So building blocks for a successful system, very similar to what Liz just spoke about, in that we need to just start with our clinical governance and executive sponsorship and direction. So when I said we got the CEO to go, yes, you will have this position and therefore you will have my blessing to do what you need to do for this system. So it started at that point then, pushed by the CEO of the organisation. In terms of clinical governance, we made sure we established a strong committee. Prior to the committee, we actually had a statewide interest group, so we had attempted to unlock that gate between north and south. We just never reached a consensus, so we kindly agreed to disagree and go our separate ways. Having said that, we do share resources, and certainly the safety and quality team, and we have clinical advisory groups for the state where we do actually try and share, but for some reason we just can't actually reach that end point, other than the goals of care work that was discussed in one of the sessions yesterday, led by Dr. Robin Thomas from the Royal Hobart. So in terms of executive sponsorship, what we did, not just for Standard 9 but for all our standards, was identify an executive person who would take on that role of pushing, directing and guiding. So not necessarily telling us what to do, but being the buck stops here person. And in that time we had our Executive Director of Nursing, That's now changed, and we have our nursing director for acute care services, so the ED, ICU and our acute medical unit. Like I said, a strong committee with representation across all areas that would be impacted. So we had women's and children's, we had paediatrics, we had obstetrics, we had our neonatal teams involved. We had membership from the various departments of medicine, so not just the acute areas, but we also had an off-site 6-minute walk across the road, slow stream rehab unit. So how do we do that? How do we set up a deteriorating patient system in that unit? We had our on-site inpatient mental health unit, so we worked with them as well. So we had to consider all those different aspects and make sure that they were involved in the committee and had a voice. Commitment from all levels, so ground up, ground and top down, and stakeholder engagement. So we have established a community advisory council, and they actually take governance for Standard 2 in the north of Tassie, and we work closely with them through our program coordinator for consumer engagement. We have clear processes. So we had our protocols at the time. In fact, I don't even know what we had then. I don't even think we had something on paper about the then Code Blue in 2011. But then we identified, and what we did was looked at, here's the National Consensus Statement. So we had that guiding document, unlike maybe other hospitals that had already had their rapid response systems in place prior to Consensus Statement. We only just had that Code Blue calling and a team that would respond. But there was a committee that worked with them, but it was more around clinical things like what size ET tube should be in the code trolley, what's the cardiac arrest rate, rather than looking at systems. So we were able to use the consensus statement from the word go. So I think that was probably for us one of the benefits, in that we had those essential principles, and so we could look and see how should it look, rather than going, we think it should look like this, let's chuck that in and see if that works. So clear set of protocols that are well communicated and understood by staff. Hello. What was that? I'm not sure. Anyway, education. So, for example, now when we implemented, we followed closely the New South Wales program, worked, contacted the Clinical Excellence Commission and the wonderful staff and crew there to look at how they had a tiered approach to their education. It's all good and well to say everyone in the entire organisation needs to understand the system, but when there's only 1 or 2 people providing that education, and you don't have, as someone said earlier, you don't have dedicated resources set aside. Going back to my creation of my position, it was created to roll out Standard 7, but that was one element of my entire portfolio of work as a safety and quality consultant. So it wasn't I was just doing Standard 9, it was just one small part. So with the education program now, we have education for our transition to practice, the nurse graduates, for our junior medical officers when they first start. The other thing that we did with our process is to make sure we have a really clear monitoring and evaluation system. When we first rolled out, we realised that there would be a lot of learnings to identify from the call reviews, so they all sat with me. So I got to do all the emergency call reviews. We then shifted that responsibility and accountability to the nurse unit managers of the area where the call was made, so that they and their trained staff could actually undertake the call reviews and feedback directly. And I think that was a key change for us, taking it away from our unit, safety and quality, to we actually have ownership. We need to identify what we need to learn from here. Some of the outcomes that we've had, we've developed a patient safety event guide for the reviews. We started, when this system started, we have the electronic incident monitoring system like AIMS. We now have a safety reporting learning system. We showed increased compliance with charting and escalation. We've shown improved communication, not just between the nursing staff, but between nursing, medical, allied health throughout the entire program. We've got our well-developed education program. Some of the quality improvements that we've undertaken over the 4 years was an actual trial on, simulated trial on developing a code scribing record. So we actually trialled that with some data analysis to see what people wanted. One of our teams that's here today developed a senior nurse review sticker, because we identified that one of the glitches we were seeing was the failure to document as nurses. For some reason, they go in and see a patient, do some assessment and think that it's okay to keep that in their head and not actually write it in the clinical record. So a simple sticker that allows them to succinctly document that. We streamlined our emergency equipment layout, and one of the massive pieces of work that Matt Brain and his team have led is our ICU database, where we can actually incorporate and locate all that data. As Jenny said, we had 5 met with merits for our org survey. We actually ended up with over 40 met with merits for our acute service at the time. I think the reason, apart from, it's not that we did anything different or better, it's not that we can show we saved more lives, but I think what we did, certainly in the lead up to accreditation, is we worked with our staff on what I've done here, except not the content. We did it for all the standards: structure, process, outcome. It's all good and well for a committee to sit in a room with a surveyor and go, we have really good terms of reference and we do this and we do that. And they go out to the ward staff and they say, so tell me about your deteriorating patient system. Oh, I don't know what that's all about. So we worked with our staff over that 3-4 year period to make sure they understood what these were. And what we actually found and had feedback from our ACHS surveyors was they went out to the wards after talking to the committees, and we did not prompt and script our staff. They walked onto our rehab ward, and one of the nurses walked up and said, oh, you're one of the surveyors, come with me, I'd like to tell you all about my patient. They're at risk of pressure injury. This is how I screened them. They had a med call yesterday. This is what I did. And on it went. And they happened across the entire building. So it matched what the committees were saying. So it's no point having strong clinical governance if it doesn't mean anything at the end, at the bedside. That's it for me.